Good morning. This is the audio lecture for Chapter 10, Loss, Grief, and Dying. As a reminder, I probably will go along these slides a little bit more quickly than if I was in real time, just because you're able to go back and listen to the audio lecture as many times as you'd like. When dealing with a terminal patient, professionals that typically deal with death believe that when fear is relieved, pain is managed, needs for reconciliation with loved ones are met, and spiritual needs are met, then and only then patients can approach loss and death without fear and with a sense of peace. When medicating the dying patient, it's important to keep in mind that it's always the patient's right to die with both dignity and comfort. We want to let the patient know that addiction is not something that we're worrying about at this point, as far as giving them stronger medications to deal with their pain. Addiction just isn't in the equation when you're dealing with a terminal patient. It's important to understand the cultural beliefs regarding patient medication. Some cultures may have different beliefs about using medications for pain. And it is not acceptable to assist a patient in euthanasia. And euthanasia, of course, is the deliberate ending of a terminally ill patient's life. So that's not acceptable and it's against the law. This slide just illustrates the connection between curative, palliative, and hospice care, which are all three things we'll be talking about today. Palliative care provides comfort care, medication administration, nursing care, and it alleviates uncomfortable symptoms. Palliative care is directed at eliminating discomfort. So it's a little bit more aggressive, maybe aggressive with pain treatment, and that's the difference between palliative care and hospice care. Hospice care, on the other hand, is for patients in later stages of terminal illness. They're in their final 6 months of life, and it focuses more on comfort than cure. Curative care is when the goal of care is healing or curing a disease process. Which type of care is that in which medications, treatment, and various therapies are provided with the intent of healing or curing a patient's illness? And that is a curative care. The primary functions of the interdisciplinary hospice team include relieving pain and discomfort, lessening patient and family fears and anxiety, actively including the patient and family in patient care and decision making, providing both the patient and the family emotional support through the various stages of the grieving process. And in order to do that, we as nurses must deal with our own personal feelings about death and dying, and then also providing respite care for the caregivers. And that's when family members are given the opportunity to take time away from loved ones without having to worry about their care. There are a couple of different ways to have end-of-life documentation. First of all, a living will is a written document prepared by a mentally competent person regarding the procedures and measures they do or do not want to have at the end of life. If someone has a living will and they have decided that they don't want their life to be prolonged any further, then the next thing the nurse would want to do is to speak with the family members before writing a DNR or do not resuscitate order. And then the durable power of attorney is when a court document grants authority to make healthcare decisions should the patient become disabled. And then, of course, a DNR or DNAR, do not attempt resuscitation order. Most of you know that implies that if heart and respirations cease, heartbeat and respiration cease, no CPR or heroic efforts should be done. And of course, if somebody does not have a DNR order, then the nurses must begin CPR if they find the patient unresponsive. What kind of end-of-life documentation determines who would make decisions for a person should they become disabled or lose the ability to make health-related decisions? And that, of course, is durable power of attorney, a legal court document that grants the authority to make healthcare decisions and act as a healthcare proxy for the patient should the patient become disabled is known as durable power of attorney. Facing loss, children in grief, and role reversal. What they're talking about here with role reversal is when children who are used to being cared for are now caretakers of their parents. So those roles are reversed. And I'm not sure if any of you have ever had to deal with that, but it's a strange feeling to be able to have to take care of your parents when you've been accustomed to them taking care of you your entire life. The other thing I want to add about children and grief is many times people try to shelter kids from grief as a way of protecting them. But generally, kids are pretty smart and they can sense something is wrong. So it's really important to be open with kids about illness and death. These next couple of slides talk about the stages of grief according to Elizabeth Kubler-Ross. So the first stage is denial. They might say, not me, this can't happen to me, it can't be happening. I can't possibly be that ill. And it's the first stage of the 5 stages of grief. Stage 2 is anger. Why is this happening to me? Why me? It's not fair. And they might lash out at the healthcare provider. They might say, I don't need anything from you. Leave me alone. And it's all part of that anger. And then stage 3 is bargaining. I promise I'll be a better person if, and just let me live to see my children graduate. If I could have just one more chance. If I just eat better, I'll be able to beat this colon cancer. If I could just see my new grandchild, I'll be okay. And then stage 4 is depression. I don't care anymore. I'm so sad. Why bother with anything? It's kind of a way of giving up. And then stage 5 is acceptance. It's going to be okay. I'm ready for whatever comes. They've kind of made amends with people and they're ready to go. And typically when I have an in-class lecture, I show a video about the 5 stages of grief. So it's the stages of grief with a giraffe. So if anybody would like to look that up online and watch it and let me know what you think about it, that would be great. 5 brief statements of reconciliation and closure that need to be said before dying. These are the most common and typical ones. Forgive me. I forgive you. Thank you. I love you. And goodbye, and giving the patient permission to go. And I'm not sure if any of you have ever been in those situations before. I'm guessing that you probably have been, and I certainly have been as well. And one thing I remember with my dad in particular was that I went in and I said, it's okay, Dad. We're all taken care of. Mom is taken care of, and they really need to hear that when they're nearing the end. Culture and religion affect terminal illness. Um, some might have a preference of dying at home or in a controlled environment. Um, Sometimes presence of family and friends or alone time for reflection and repentance. Loud moaning and chanting during the final hours. And also, many religions want the presence of a spiritual leader um, present at the time of death. Maybe Catholic wants last rites read before they pass away. The dying process involves psychological and emotional changes, a lot of introspection and reflection on their lives. They tend to have an increase in sleeping to detach themselves. They have a loss of interest in food. So, really, the only thing that we can do is to encourage foods that look and smell appealing. And then they might have some confusion. And the most important thing we can do as a caregiver is to protect them from injury, maybe by using protective equipment or having the bed rails up. During the dying process, there's a lot of physical changes. With the vital signs, the blood pressure decreases. Pulse is up at first and then it decreases. So it might be up in the 140s and then drop down into the 30s. With the skin, there can be sweating and clamminess. They might be flushed. They might have what's called circumoral cyanosis, which is cyanosis or that bluish skin around the mouth. Respiratory changes, it can be very high, can go from 40 to 50, and then very low, 6 to 8. And you know that the normal respiratory range is 12 to 20. Physical activity, they tend to be restless. The two biggest factors that affect the restlessness is fear and unfinished business. Their eyes can become glassy. They can have some tearing because of dry eyes. It isn't because they're crying. And then circulatory changes. Their hands and feet can be cold and cyanotic due to decreased circulation. They can have mottling, which is mottling, patches of varying color, pallor and cyanosis, so paleness, bluish. Getting back to the respiratory changes, one thing I wanted to mention about that is near the end, they have what they call Cheney-Stokes respirations, and many of you have probably heard of that before, but it's that cycle of shallow and deep respirations. Um, and then the other thing I wanted to mention about respiratory changes is there's sometimes an accumulation of secretions in the trachea, and that you want to make that a priority to address because it can be really scary for the family. Sometimes it's called the death rattle, if you've ever heard of that. If the secretions are up high in the throat, it can be suctioned, but if it's low, you can help it with positioning, and also you can give medications to help dry the secretions. And in the end, when a person passes away, their breathing stops and then their heart stops beating within a few minutes after that. And then the other thing that might happen physically during the dying process is the patient might get dehydrated. And actually, they can actually be more comfortable if they are dehydrated. And the reason for that is because there's less edema and discomfort from ascites, which is swelling in the abdominal area. They also might have decreased urinary output, so they don't have to go through the pain of getting up, getting to the toilet. And then also another reason that they might be a little bit more comfortable if they're dehydrated is there's an increase in endorphin production, and that decreases the perception of pain. The hearing, I'm sure many of you have heard this, hearing is the last thing to go. So you need to really be careful when you're in the room of a dying patient, because they can hear all the way up to the very end. Nursing care, the most important thing is to show caring through touching and listening. Also teaching the family how to help with their care and what to expect. In the book, in box 10-1, by the way, it lists all the signs and symptoms of end-stage disease, and I thought that was a really good and all-inclusive list. Observation and provision of comfort. We want to address and observe pain and nausea, gas exchange, the moisture of the mucous membranes, emotional or spiritual distress, positioning, and elimination. So those are the areas that we are going to be addressing. The other thing that we may end up addressing while we're in there is if they have a readiness to talk about dying and just being there for them. If they say, what do you think death feels like? Or begin asking specific questions about death, then that may be an indicator that they want to and are ready to talk about the possibility of them dying. And then we want to maintain symptom management with pain management. Again, I mentioned in an earlier slide, addiction is not a concern during the terminal stage of illness. We want to manage their symptoms of nausea and dyspnea as well. If they don't want to take any medication for the dyspnea, you can always do non-pharmacologic interventions, maybe like putting a fan near the bed to help with air circulation. And then signs that death is nearing, back a couple of slides, is they're non-responsive. They have that slow, thready pulse. It's already been up high and now it's low. And the modeling of the feet and legs, which I mentioned. And they might also have lower extremity edema because of decrease in circulation. And then these next several slides are on postmortem care, and I'd be interested to hear if most of you have performed postmortem care. I think I'm guessing that most of you have, but we'll just go through these slides here. First of all, assessment steps, safety, make sure the identification of the patient is correct, determine if there's family members or clergy to notify, determine whether or not an autopsy needs to be performed and has an autopsy permit been signed, and determine if the family members would like to assist in bathing the deceased loved one. Some cultures are like that, where they want to assist. It's the last thing they can do for their loved one is to assist with the preparation of the body. And the planning steps: obtain necessary equipment and clean linens and gown. If there's a roommate, make sure you help them to leave from the room. Make sure the door is closed and the privacy curtain is pulled. Plan to handle the body with all due dignity and respect. And then respect cultural beliefs and spiritual practices. Implementation steps for safety reasons. Always want to wear clean gloves to protect yourself from the body fluids. Bathe the body to remove all the body fluids, including blood, emesis, drainage, urine, or feces. Put a disposable pad under the hips to absorb any further drainage. And the note here is in certain cultures, this step must be omitted. Some religions strictly forbid washing. In others, a special person must perform this task. And in cultures in which the family's washing of the body is considered the last service that a family can give a loved one, and I mentioned that, the family should be given the necessary supplies and left alone in the room with the body. Comb the hair, apply a clean gown and linens as needed. Put the patient in a supine position. Leave dentures in place unless facility policy says to remove them. And if that's the case, make sure you store them in a denture cup and make sure the mortician gets those to keep with the body. And then you also want to gently close the eyelids. And if they don't close, you can use a moist compress to moisten them for a few minutes, and then you should be able to close them. Sometimes they can use a strip of gauze or even a washcloth underneath the chin if needed to hold the mouth closed because it'll open otherwise. Put a pillow under the head and shoulders. Be sure to keep all the dressings intact if an autopsy is going to be performed, and if not, apply clean dressings. With an autopsy, you want to leave tubes in place. Clamp them, cut them off approximately 6 inches in length, fold over the cut end of the tubing and tape it closed, and leave original dressings in place. If there is no autopsy, remove all tubing, oxygen tubing, Foley catheter, drains, nasogastric tubes, IV lines, and apply a bandage to prevent leakage, and then apply clean dressings. That's without an autopsy. Put the hands across the deceased person's chest to prevent discoloration due to pooling blood. Allow the family to view the deceased patient and stay as long as they'd like. Stay with them to offer emotional support unless they state that they prefer to be alone. Once the family leaves, then call the mortuary if the body's to be transported. You want to put the ID band on, toe, ankle, or wrist according to facility policy. Again, if facility policy dictates, secure the wrists together and the ankles to make transport easier. If a shroud is to be used, which is just basically a garment to wrap the body in, then you want to place the body supine and follow the directions on wrapping them in the shroud. If no shroud is needed, cover the body with a clean flat sheet to wait for the mortician. Transport the body on a gurney to the hospital morgue unless the mortician comes to the room to pick up the body, which I believe is normally the case. And of course, common courtesy dictates that all the other patient doors be closed before transporting the deceased patient down the hallway. Make sure that all the documentation has been done according to facility policy. Make sure that all the family members' needs were met. And then also make sure housekeeping knows that there is a terminal cleaning of the room. And then the last thing is to make sure that all documentation is done appropriately. And I do want you to read through that sample documentation in the chapter. And again, if you have any questions, don't hesitate to email me, but you're free to listen to this audio lecture as many times as you need to.